Subject 9903, embryo 1, day 1. Day 2. Day 3.
We're looking at the beginning of a potential human life, an embryo, a small group of cells with huge potential. The miracle of life still makes us wonder which embryo will develop into a healthy child, and what can we do to ensure pregnancy?
We still need, for sure, to improve our performance in assisted reproduction. It's always the end point to have more pregnancies, but it's also end point to have a good tolerability and a low risk.
For decades, in vitro fertilization has been an invaluable tool in our work to help many couples with a desire to become parents. The treatment has been continually improved and refined, but between 2 and 3 out of 4 treatment cycles still fail.
If I think how we have to proceed, I think we have to analyze and to study different stimulation protocols, more in depth, at all different levels, egg, embryo and endometrium. And I think this is the crucial point.
In 2004, the Clinical Research and Development Department at Ferring Pharmaceuticals initiated the multinational trial entitled MERIT. The rationale for MERIT is based on the findings of a reanalysis of a previous large comparative study that suggested that pregnancy rates in IVF cycles differ depending on which hormone preparation women are stimulated with. In that trial, highly purified menotrophin gave significantly more pregnancies than recombinant FSH. MERIT prospectively addresses this controversial clinical issue. MERIT is entering its final stages and the results are expected in 2005.
The question is, does the urinary divide purified gonadotrophins containing both the so-called FSH and LH activity, does this preparation give a higher pregnancy rate than recombinant FSH? And this is the hypothesis. It's designed and it's planned for the purpose of finding out whether this is the case or not.
Next one's the one with the
MERIT is an assessor-blinded, randomized controlled trial that includes 731 subjects, each attending one of the 35 participating clinics across Europe and Israel. In order to participate in MERIT, every clinic has to set aside local routines and adopt standardized procedures that are uniform for all clinics involved.
Within the MERIT, I think they have gone a bit further than anybody else has done before in way of making very tight limits about very clear definitions on any procedure. They do not allow, for example, that you give different drugs for downregulation. They don't want you to give different drugs for how you administer HCG. It's very well defined that you have to give HCG when you see that that there are 3 follicles of 17 or more. You cannot postpone it for 3 days, for example, during a weekend if you want. You have to give it. They have made the same luteal support, and they have defined how long you should continue with the luteal support. So there have been attempts to minimize variability in the clinical setting.
They are the files from MERIT study.
To ensure speed in the collection and validation of the data, clinics register their data on an internet-based system. Any errors can thus be discovered instantly when the data is entered. At the same time, the data is registered centrally at Ferring Pharmaceuticals for continuous quality validation and for rapid evaluation on completion of the trial.
We should, in fact, always try to do and to use very strict protocols, otherwise you cannot analyze anymore your primary goals and endpoints.
Embryo 4, day 1.
In the course of 2004, a team of 3 independent embryologists met frequently to carry out a centralized evaluation of embryo pictures. The participating clinics have been able to provide the team with daily photos of the developing embryo, with the help of a computer system custom-made for this trial.
There are many different scoring systems which are used, and they're very hard to compare between clinics.
That's one of the problems, and I think that's one of the things why this central embryologist screening is important, scoring, because each embryologist in the different clinics, they have their own way of scoring and they stick to that.
Day 2.
The impact of scoring this, as we do here, is that the result should be much more homogeneous, because we don't have the variation between clinics. We have the time to study things. I mean, we can measure things. If whenever in doubt, you can just measure them, and it should get you a much more objective.
We need a lot more data and information on what is the right embryo and specifically how to select it.
For most of these type of studies, they have looked at the endpoint pregnancy rate, and usually that's it. Or sometimes it's only the number of eggs you get out. So I think this is a new thing coming now, that also embryo quality has to be included.
Well, looking to the embryos, it's probably the way to increase the pregnancy rates, because the embryo, more and more people are transferring only one embryo. So we have to be able to select the embryo with the best implantation potential.
Day 2.
The amount of data we have is enormous. So if we, with the criteria we had, were able to really spot the best embryo, then it will be a tool for all clinics worldwide.
Long-term aspects covered in MERIT include a follow-up of the quality and outcome of frozen embryos derived from the study, and documentation of live births of all pregnancies from fresh and frozen cycles.
If there are differences between the two drugs in relation to pregnancy rate, then it could be due to various things. But if you have differences in cryopreservation results, then you know that it's really the embryos primarily that the biological explanation is more likely to be linked to the embryo, because then you replace them in the woman's natural cycle or a well-defined cycle system.
One of the many other investigational aspects of MERIT is to take a closer look into the effect of type of gonadotrophin preparation on the follicle fluid and the process of oocyte maturation.
In the MERIT study, the aim is to compare two very well-defined hormone preparations and to study their impact on the intrafollicular environment and the maturation of the oocyte, because it has been shown by previous retrospective studies that indeed it is important to have a certain combination of hormones administered to the woman in order to get the best quality oocytes. And so the idea now is to study more this follicle fluid in order perhaps to define a panel or a group of markers that would be more predictive on an individual basis for the quality of the oocyte. So this would enable us to know on beforehand, perhaps before puncturing the follicle or even before fertilizing it and culturing it in vitro, to know which oocyte has the potential to go into the full development of an embryo.
Yeah, that's true.
All the changes are being checked again, no? I did check.
So they have updated data, but it's just not on the list yet. Or?
If you do the large multi-center studies, I think you should try to have a standard that is comparable to what has been done here in the MERIT. It would be an ideal situation if such trials could be undertaken also without the range of the pharmaceutical companies, but it's absolutely impossible. It needs a lot of financing, it needs a lot of logistic efforts to make such a program running, and it's far, far, far beyond from what you could do, even though you had several large university clinics collaborating. It would be far beyond their possibilities from a logistic and financial point of view.
MERIT is expected to give us a qualified answer to the controversial question of what difference various gonadotrophin preparations can make in IVF treatment.
It has been seen after the first publication that in IVF patients, and I'm not talking about ICSI patients, that in IVF patients there was a difference between the two different compounds. And I think it is very interesting to know why this difference is there, and in a large study group, if the difference is still there. I think these are the two main factors. I do not know anything about the results today, but it would be very interesting to know if there is still a difference, and of course then one has to think why this difference is there.
It would be nice to have not just a possible answer, but also some kind of biological explanation.
But MERIT goes even further. It is expected that the large database of this study will contribute with valuable new scientific information in the field of in vitro fertilization.
At the end of the whole exercise, having the possibility to combine data coming out from hormone analysis of follicle fluid, putting this data together with a lot of observations on the embryo development, the embryos generated from oocytes coming out of these fluids. If you put all this information together in a database, you can start to look to correlations of certain factors in relation to embryo development. First of all, oocyte maturation, then embryo development, but also live offspring.
This is a unique database, and I'm sure that we're going to use the database a lot and do a lot of research and study based on the data collected in this study. So that's very unique.